Good evening. Marhaba. It is a pleasure to be the recipient of the hospitality of Abu Dhabi, the support of the NYU Abu Dhabi Institute, to participate in this evening's event, but also on behalf of the 50 or so experts who've given up their time to be part of a workshop that completed its first day. And as has been described, is starting to think about ways that we can develop global methods of communication and sharing of knowledge and transmission of effective ways to start transforming our health systems to better address common mental disorders and conditions. These groups of disorders have long not been part of the global conversation about health, but have more recently emerged as important conditions in terms of population disease burden on the effects of people to be able to perform basic functions in daily life, and also the impact of mental disorders on other medical conditions. Several of the people on the panel are, in fact, very much responsible for that increased global attention and global action towards mental disorders. And they're going to be the first ones to speak about a world perspective on developments around rethinking and identifying and prioritizing mental health as a global health issue. The first of those speakers will be Dr. Shekhar Saxena. Dr. Saxena is as approachable and generous as he is wise and influential in really being a strong advocate for translating what we know about the importance of this disorder into global action. He'll be followed by Dr. Vikram Patel, who is often referred, I think maybe behind his back, as one of the fathers of the field of global mental health, really establishing a lot of the foundational research programs and strategies to underscore the importance and the relevance of common mental disorders globally, especially in low-income countries where they were considered marginally important before a lot of his work and work of others. So after that global perspective, we're very honored to have following Dr. Amna Al Marzouqi, who is the project manager for the Abu Dhabi Mental Health Program, to talk about how locally these kinds of issues are being addressed within the health system here. And I especially appreciate Dr. Al Marzouqi coming because she's battling what sounds like a cold, and we appreciate you being here. We'll take questions after all the presenters are completed, and we'll begin with Dr. Saxena.
And thank you very much, New York University Abu Dhabi Institute, for giving me a chance to be here with you to contribute to the workshop that is extremely interesting and relevant for us in WHO, and also to invite me for this evening session where I can share some of my thoughts on global mental health, especially around challenges and opportunities. And mind you, there are both challenges and opportunities with you, and then discuss these issues with you. I'll begin with the UN General Assembly resolutions, and there have been many. This particular one was in 2004, which talked about the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Also, let's remember that World Health Organization, for which I work currently, declared right in its constitution in 1947 that health is a state of complete physical, mental, and social well-being. In fact, it goes beyond mental, it goes into social well-being as an important part, an essential ingredient of health. but even now, the state of mental health in the world seems to be not following the high standards that were set by these organizations. UN Millennium Development Goals, developed many years back, did not talk about mental health as such, but identified 3 important challenges out of the health area. Number 4, reduce child mortality. Number 5, improve maternal health. And number 6, combat HIV, AIDS, malaria, and other diseases. But the fact is that mental health is not a part of MDG, but contributes to their achievement substantially, not only for health, but also for the other developmental Millennium Development Goals. And that way it underpins, it contributes to many other things without being quite visible in some of these very high level programs. Very recently, in September 2011, there was, as you are perhaps aware, a very high level meeting on the prevention and control of non-communicable diseases, convened by the UN again, held in New York, and that talked about the non-communicable diseases and did not include mental health as a substantial part, but did refer to the recognition that mental and neurological disorders, including Alzheimer's disease, are an important cause of morbidity and contributes to the global non-communicable disease burden, for which there is a need to provide equitable access to effective programs and healthcare interventions. This was said, this was signed by prime ministers and presidents and many health ministers. Almost all the countries were represented in this meeting, and it did reinforce, it at least recognized that mental and neurological disorders cause burden and there is need to provide effective programs and healthcare interventions. Looking at the disease burden, you know already that mental and neurological diseases give rise to almost 13% of the total disease burden measured by DALYs, which is one of the common currencies for this. But I am presenting a slide which is not often presented. This is the disease burden amongst women 15 to 44 years of age, and you can see the top conditions which give rise to this burden. Unipolar depressive disorders comes right at the top, followed by schizophrenia, bipolar disorder, self-inflicted injuries, panic disorder, migraine, and alcohol use disorders coming pretty high in this list. And this is true not only for high income countries, but also for low and middle income countries. So the myth that mental and substance abuse disorders are common in high income countries and are yet to become a leading cause of burden in the low and middle income countries is completely untrue. This slide proves that. There are many conditions which are common, are becoming more common, and giving rise to a lot of burden in these countries too. Coming off from the disease burden, taking the economic side of mental disorders, these are figures recently published by the World Economic Forum, not by WHO, but they are worth looking at. And the cost of illness, mental disorders, the value of future lost outputs, and the value of lost lives are all in $1 trillion. At least I can't figure out what $1 trillion is. My count stops at hundreds and thousands and maybe million, but as soon as it becomes billion and trillion, I lose count of it. But that's what the economists tell us, that mental disorders are responsible for a very large amount of economic burden, and these figures are increasing. If you look at the 2030 estimates, they are multiple times compared to the estimates in 2010. And so the burden is large in terms of disease, the burden is large in terms of economic impact, and is going to increase. We were fortunate to be part of the Lancet series on global mental health 2007, and the Lancet editor chose just a single line to put on the cover. Why do we invest so little in our mental health care? And I think that summarizes the situation very well. It's a question. We don't know why, but that's a fact. We invest very little in mental health globally, as well as in most countries, I would say, high income and low income, and by communities. Are we really investing into our mental health as communities, as families, as individuals? And I think the sad answer is no. Let's figure out what could be some of the aspects that we need to remember when we are talking about mental health. The same Lancet series talked about the resources for mental health, which are scarce, not distributed in an equitous manner, and also utilized very inefficiently. The same Lancet series had a call for action, which was part of the 6th review, which me as well as many other colleagues here were part of. And the call for action was to scale up the coverage of services for mental disorders based on an evidence-based package of services and strengthening the protection of human rights to persons with mental disorders and their families. The call did not talk about discovering new drugs. The call did not talk about mental health promotion for everybody. The call talked about increasing the coverage of services, and that is quite significant. And the fact is that majority of people who suffer from mental disorders are not receiving the care that they should. So the call for action is to provide services and care and to protect the human rights of people who suffer from mental illnesses and the indignity of being at the receiving end of human rights. We publish in WHO for the last 11 years a series of atlases, and we call them the Mental Health Atlas. We published the last one in 2011, just 2 months ago. And this is, to our mind, a mirror that we put in front of society. This is what you are investing in mental health. Mental Health Atlas covers the essential policies, legislations, the amount of human resources that are there, the infrastructure which exists for mental health, and the money that goes into mental health from each of the countries. And the findings are really eye-opening. We are investing, again, very little for mental health. The key messages again are the resources are insufficient, they are inequitably distributed and inefficiently utilized. Let's take a couple of examples. Insufficiency of budgets. Overall, the amount of budget which countries allocate for mental health out of their total health budget is 2.8%. That's the average. And still there is a lot of distribution amongst the countries. High income countries spend about 5%, which is far less than what the burden is. Their burden is more like 20% because of mental disorders, and they spend on an average 5%. And the amount of budget which is allocated by middle and low income countries is extremely small. Remember that they have a small amount of total budget, a small amount of health budget, and out of that they allocate, even percentage wise, a much smaller amount for mental health. It leaves hardly anything for mental health. How are human resources distributed across the world? This is a map from our recent atlas, and all of this can be found online. So you can just type in Mental Health Atlas 2011 and you will reach the site, and all of that is available. Almost half of the world's population lives in a country where on an average there is one psychiatrist or less to serve 200,000 people or more. There are countries in Africa which have a population of 19 million and 2 psychiatrists, a population of 4 million and no psychiatrist. That's the state of human resources, the specialist mental health resources in many of our countries. And inefficiency, whatever little money we have, we are putting that into psychiatric beds, especially in mental hospitals. 62% of all beds in the world which are for people with mental disorders are located in mental hospitals. And we know that mental hospitals provide a particularly inefficient way of utilizing scarce resources. They care for a few people, they care for people who are chronically ill, and more often than not, they are custodial in nature, providing less treatment and more control, more a place to keep people who will be dangerous to society and not really care. And that's the state of affairs. We're spending all our money on that, leaving hardly anything for a number of people. The word a billion minds and lives is not much of an exaggeration. There are 450 million people in this world right now who suffer from clear, diagnosable mental illness, and about 70–80% of them are not receiving anything. That will not happen in mental hospitals wherever beds are. So the consequence of all this is that majority of people don't receive any care, and this particular slide is from 2004. I believe the situation has not changed much after that. And remember that even in developed countries, the proportion of serious cases receiving no treatment is between 35 to 50%. This is the state of affairs in Western European countries, in France, in Germany, in UK, in USA. And in developing countries, the situation is far worse. 76 to 85% of people in this particular study did not receive any treatment the last 12 months. So the fact is that the majority of people have no access to treatment, and that is a reason for collective shame to many of us who are trying to advocate for more resources and more mental health care. The Lancet series 2007 was followed by another series in 2011, and one of the papers that I was again fortunate enough to be part of talked about scaling up care for services for mental health in low income and middle income countries. And the findings are, there are many examples of diverse mental health programs offering services including low and middle income countries. Many are not based on sound evidence, though many are doing good work. Few are evaluated and many hidden from view, and only a few examples of systematic scaling up could be found. So in spite of 4 years between 2007 and 2011, we could find only a few examples of systematic scaling up. New resources are available but not yet being accessed by service implementers. Mixed response on progress at national level and lack of systematic data currently makes it impossible to accurately compare coverage or finances across time. So we found it difficult to say how much resources have increased, how much more services are available, and we don't even have very good indicators to really assess how the situation has improved. But certainly the situation has not improved very much, otherwise it would be quite visible to all of us. The same Lancet series is also talking, and this is an important point because we are looking for more services, more efficient services, but also services that respect the human rights of people. And the 6th review in the Lancet series 2011 focuses on human rights violations of people with mental and psychosocial disabilities, and it calls it an unresolved global crisis. Stigma and discrimination are widespread. They pervade human rights violations for people with these disorders everywhere, and these violations span basic civil, cultural, economic, political and social rights. In many countries, people with mental disorders are not allowed to vote, they are not allowed to drive, they are not allowed to stand for any elections, and these are fundamental civil rights of people which are flagrantly violated. And in many of these cases, once a person with mental disorders, always a person with mental disorders. People do recover, but they don't recover their rights, and that is the crisis that this article is talking about. The pictures are many. They really paint a very bleak picture. The people who are chained, the people who are tied down, the people who are denied basic food, basic clothes, their basic survival rights. And that is the state of affairs in many developing countries, but sadly in many developed countries too. What is the response of the organization that I work for, the World Health Organization? I'll describe in the next very few minutes some glimpses of it, but I'm very happy to talk to any one of you who's interested in this kind of work. We, after the Lancet series 2007, we launched a program which we are calling the Mental Health Gap Action Program, gap being the gap between what is needed and what is available, which obviously is very large. This program is an integrated service development program that is sustainable with the objective of scaling up care for multiple priority disorders using health system approach with evidence-based and rights-based interventions on a total population basis with measurable impact. So essentially it's about scaling up services in areas, especially in areas where services are very much lacking. The underlying logic of this program is that the burden budget gap that I described earlier should be reduced, mental health services should be organized rationally, and human rights abuses have to be stopped. just giving you an example of the service organization, this is our model of how services should be organized. At the bottom, there should be self-care and informal community care, which should be available in high frequency. That means almost everybody should have access to that, and they cost very little. Going above that, mental health service in primary health care, general hospitals, and mental health services in community care should be available to whoever has the need. That means the frequency of need will be less than what is lying at the bottom, and the cost is obviously higher. And finally, at the top is a few specialist services which should be available for people who cannot be treated in general hospitals, require much more specialized care. It's obviously very expensive and should be available to only those people who really need it. In most countries, services are few, but they're also organized with the pyramid really completely upside down. Whatever services are there are specialist services, and nothing is there in general care, in primary care, or in informal community and self-care. Our task is to put this pyramid the right way. I am told, and perhaps we'll hear more from one of the speakers, that Abu Dhabi has very good mental health services, but again, they're not perhaps available in primary care. From WHO, our stand is, even if you have sufficient number of specialists, which very few countries have, it is quite essential to have mental health services integrated within primary care, because that's where most people go for their health problems. And if the detection of mental disorders in those services is not there, you are losing out, you're missing many people who should be receiving care. So from our side, the message is, have services organized in this way, if possible. We also have produced an intervention guide, which is evidence-based interventions for selected disorders, and they can be delivered in non-specialized healthcare settings. Finally, what should we do now? I have just painted a picture which looks very bleak. Are there any things which can be done with the existing knowledge which can be done now? Yes, there are many things which can be done. One is we have to find ways in which the resources flowing into mental health increase. We have to use the knowledge that we already have, and I'm very happy to be part of the learning network which is being talked about currently by the New York Abu Dhabi campus, and then going ahead and seeing how that knowledge can actually be used by people who are on the ground level and are trying to look for knowledge which they can use today. We have to facilitate stronger civil society movement. We have to train manpower. We have to scale up services. We have to decrease human rights abuses and monitor the situation with very specific and sensitive indicators which can tell us whether we are moving forward or not. I would end my presentation with a quotation from the United Nations Secretary General, who on 10th of October, which happens to be the World Mental Health Day, said, and I quote, "We have the knowledge, feasible, affordable, and cost-effective measures for preventing and treating mental disorders exist and are being implemented, for example, through WHO's Mental Health Gap Action Program. However, if we are to move decisively from evidence to action, we need strong leadership, enhanced partnerships, and the commitment of new resources. Let us pledge today to invest in mental health. The returns will be substantial." Unquote. Thank you very much for your attention.
Good evening, friends. I'd also like to start by thanking Gary Belkin and the New York University Abu Dhabi Institute for this opportunity to be with you this evening. If I could have my slides. I think my talk will follow quite nicely on from Shekhar's last slide, which really described the key actions that were needed to address this incredible burden of mental disorders, the incredible challenges, in fact, a different kind of challenge that he described in terms of the burden, the unmet need for care, the very poor response to this unmet need for care. And that's the initiative that I'm about to tell you about, which is the Grand Challenges on Global Mental Health. Before I start, I should just simply say that this initiative, I speak on behalf of the entire Executive Committee and the Scientific Advisory Board of this initiative this evening, but in particular my two co-authors, Pamela Collins from NIMH and Abdallah Dar from the University of Toronto. both of whom have their own unique grand challenge this evening of trying to be in 2 countries at the same time, which in part explains why they're not actually physically here this evening, unless Abdullah has been miraculously beamed into this room. But I can't see him here, so he's certainly not here this evening. I want to start by, first of all, just reminding ourselves a little bit about some of the terms that I've used here, the grand challenges and global mental health. There are many different definitions of global health, and this is one that I've picked out, which has been used by the Institute of Medicine for the US. And what I want to really highlight in this definition is the global in this definition. The fact that mental disorders are of global significance in their burden and distribution, but also very implicit in this definition is the idea that we need global cooperation to address these problems. Another very important phrase that also occurs, I should just say, it's in the context of the framework of a global health system. Setting an agenda, setting the priorities for action is an extremely important first step before one can actually allocate resources, carry out necessary research, implement and deliver the services that arise from that research, and then in a continuing feedback loop, monitor, evaluate, and constantly refine our programs. So that's a definition for global health. What about a definition for this rather curious word, grand challenges? Well, apparently we have to go back more than 100 years to a mathematician who was from Germany, but strangely has a fairly English-sounding name, who listed in 1900 about 23 what he called mathematical puzzles. These were grand challenges in his view, and apparently mathematicians have been busy for the whole century trying to answer these. I understand that most of these challenges have now been solved, which probably explains why children these days aren't very much inclined to mathematics. Now, we've taken this particular term, grand challenges, and applied it to global health. And in that particular context of global health, the word grand challenge here refers to a specific critical barrier that, if removed, would help solve an important health problem with a high likelihood of global impact through widespread implementation. Each of the words in this particular definition are quite crucial when we think about the sorts of priority setting exercises that have happened in the field of grand challenges. Now, the first grand challenges in global health was funded by the Gates Foundation. It was published in 2003. Altogether, 14 grand challenges were identified in a priority setting exercise that I'll describe in a moment when I talk about the mental health grand challenges. But what's very important about the outputs was that they were then backed by very substantial new resources, financial resources, not just from the Gates Foundation, but also from a number of other donors, and including new funding mechanisms to support the 14 challenges. Now, these challenges specifically focused on infectious diseases and maternal and newborn and child health. And examples of such a challenge might be to improve the availability and access to childhood vaccines. Now, it was soon followed by recognition that while these were very important challenges, or these areas of global health were of great importance, there was another very important forgotten area of global health, and that was non-communicable diseases. And so there was a new initiative, a second initiative, to examine the grand challenges that specifically addressed non-communicable diseases. And that particular exercise was published in 2007 in the Nature journal. Now, this particular grand challenge did not, in fact, focus on mental disorders. It focused predominantly on the modifiable risk factors that cause cardiovascular disease, diabetes, and cancers, which, of course, between them really account for more than half of all the deaths in the world, including in low and middle income countries. Nevertheless, this grand challenge, as I mentioned, did not acknowledge mental illness. Following the publication of this grand challenge, the Global Alliance for Chronic Disease was formed, which is in fact chaired by Abdullah Dar. The Global Alliance is another new funding mechanism. Just like the first edition of the grand challenges, this second edition was followed by a new consortium of 8 of the world's leading research funders, including the National Institutes of Health of the US and their equivalent country-level partners in India, South Africa, Canada, and a number of other countries. So they collected together, formed a new funding mechanism in order to allocate resources to back these grand challenges on non-communicable diseases. Now, in the first board meeting of this new consortium, there was a strongly held view amongst the board members that the work of the grand challenges needed to continue because of the unaddressed mental health dimension of non-communicable diseases. The Global Alliance initiated a discussion with the National Institutes for Mental Health of the US, which together then launched the initiative that I want to present to you this evening, the Grand Challenges in Global Mental Health. This is the third edition of the Grand Challenges initiatives and was backed by the NIMH. The Global Alliance, which I already mentioned, includes 8 of the world's leading funders, and they were also joined by the Wellcome Trust, which is one of the world's leading medical research funders based in Britain. Now, many of you will be familiar with a number of other priority setting exercises that have been carried out in recent years, particularly focusing on the unmet need for care for people with mental disorders. So what was new in this particular Grand Challenge initiative, this priority setting initiative? Well, the first was the global scope. And when I use the word global here, I mean the idea that people both in rich as well as in less well-developed countries were involved in this exercise. This was not purely about the needs of people in developing countries, but was in fact global in its scope. It used a very systematic multi-round Delphi process to establish the priorities. Very importantly, and I'll return to this a little later, it covered the full range of what colleagues of mine have sometimes referred to as disorders of the brain and the mind. That is to say, disorders that we would classify as mental, neurological, and substance use disorders, and that it was explicitly backed by a community of research funders whose goal it was to act upon these challenges once they were published. This shows an overview of the work of the Grand Challenges and the timeline. As you can see, it started in the spring of 2010, and we published the findings just a few months ago in Nature. I'm not going to go through this in any detail, but simply just pinpoint some of the important issues that are shown on this slide. First of all, that more than 400 individuals were invited to participate from around the world, about 2/3 who live and work in the developing world. And we had fairly good response rates to both the first and the second round. During these 2 rounds, about 1,500 odd challenges were actually initiated by the respondents. We then, through an iterative process, reduced the number of challenges down to 154, which were then ranked and then further rated in a more detailed rating dimension exercise that I'll talk about in a moment. The findings were published in Nature a few months ago, and the 25 challenges that emerged as priorities could be organized around these 6 broad themes. First, to identify the root causes, risk and protective factors of mental, neurological, and substance use disorders. For the sake of simplicity, I'm going to refer to them as M&S disorders. Second, to advance prevention and implementation of early interventions. Third, to improve treatments and expand access to care. Fourth, to raise awareness of the global burden. Fifth, to build human resource capacity. And finally, to transform health system and policy responses. Now, under each of these goals, there are a number of specific challenges which you can find out more about by looking at the article, which is also available open access. Now, if you remember, I'd mentioned that in round 3, the final round of the Delphi exercise, we presented these 25 challenges to our panel and asked to rank them according to a number of different dimensions, such as, for example, the likelihood of producing a very immediate reduction in the burden of M&S disorders in populations and the feasibility of implementing these given the current resource allocation context. So what emerged as the top 5? This slide shows the priority actions that emerged in terms of these different dimensions of disease burden reduction, impact on equity, immediacy of impact, and feasibility. And what's interesting when you look at these 5 top challenges, that they speak directly to the sorts of issues that Shekhar before me spoke about in terms of the goals of the World Health Organization's MHGAP program. They seek to, first of all, integrate screening and core packages of services into routine primary health care, to reduce the cost and the availability and supply of effective medications, to improve in particular children's access to evidence-based care. And this really recognizes that the treatment gaps that you saw presented in the earlier presentation are even greater, in fact, if you look at a specific demographic group of children, to provide effective community-based services for people with disabling M&S disorders, and to strengthen the mental health component in the training of all healthcare personnel. However, I think it's also important to recognize that while all of these priority actions are largely directed towards health policy and health services, that in fact even if we could provide the best available care to all people with M&S disorders today, the reality is that because of the limited effectiveness of many of our interventions for many of these M&S disorders, a significant proportion of people with these disorders would remain unwell and disabled. It is important to recognize the limits also of the knowledge we already have. And so the Grand Challenges also identifies a number of other discovery challenges and recognizes that future breakthroughs are likely to depend on discoveries in genomics and neuroscience, as well as an exploration of the role of sociocultural and environmental context so that we can improve the effectiveness of the interventions and expand the range of interventions that are currently available to help people recover from these conditions. Now, why are the Grand Challenges important? Well, as I already mentioned, they offer a common and global vision for the field. And I think here, again, I'd like to emphasize that global has two meanings. First of all, global in that these disorders affect people around the world. There is no particular country or group of people who are immune from these conditions. But also the idea that global means that we need to actually be researching and delivering services in all parts of the world equitably. Another very important aspect of these Grand Challenges, and again a point that differentiates them from other priority setting exercises, is that they seek to bridge two very different kinds of gaps. The first gap is between the different medical specialties that have, as it were, divvied up disorders of the brain and mind between themselves, such as psychiatry, neurology, development medicine, and so on. And secondly, to also bridge the gap between clinical medicine and practice with public health. Now, explicitly, of course, the primary audiences for the Grand Challenges are research actors, donors, researchers, research consortia. However, it's also very important to recognize that the challenges also offer very specific directions for health policymakers, health planners, and civil society for action. What actions might they be? Well, for research donors, clearly now the Grand Challenges offer a very clear set of priorities to back their resources. We're very delighted, in fact, to see that soon after the publication of the challenges, a number of research donors have already, in fact, reoriented and realigned their research funding towards the challenges. Two specific calls that actually directly ask for applications for the Grand Challenges are one by the Grand Challenges Canada and another by the Government of India's Department of Biotechnology's Neuroscience funding panel. But in addition, we can expect funding from a number of other donors, such as the Wellcome Trust. The NIMH has added 2 more international hubs to its already the 3 that it's already funded, and the Global Alliance itself, of course, which initiated the Grand Challenges for Global Mental Health, which will also be soon announcing calls for application to respond to these challenges. For researchers, obviously, there is a great opportunity to use these challenges to build new global consortia, but the consortia that already exist, such as, for example, the DFID-funded PRIME Consortium and the NIMH hubs, there is an opportunity to align some of their programs of work around these Grand Challenges. What about the other important actors? For policymakers, as I mentioned, I think these challenges clearly indicate the need for equitable resources to ensure equitable access to mental health care. As you saw, the top 5 actions are really all centered around improving access to care. And for professional groups and civil society to unite and promote the themes of these challenges. And in this particular regard, I'd like to highlight the great push for mental health of the World Federation for Mental Health, which in partnership with the Movement for Global Mental Health is specifically aiming to further Goal F. I can see Vijay Ganju, the Secretary General of the Federation, here this evening, and perhaps he might have a few words to share about the great push during the discussion. Looking ahead, very much, in fact, very similar words to what the UN Secretary General had to say. We've used very similar language, actually, in the final closing remarks of the Nature paper, and I'd just like to read that out. Even incremental progress in addressing the grand challenges in global mental health could lead to significant economic and quality of life benefits that very, very outweigh investment costs that might have to be incurred. So finally, just want to acknowledge the various groups that have funded the Grand Challenges and made it happen. Thank you.
Great. In my agenda today, I'll give you an overview about the mental health disorder in the Emirate of Abu Dhabi. This is from the literature search and from the WHO's report, which has been carried out by the Health Authority of Abu Dhabi. Then I will give you an overview about the current mental health services in the Emirate of Abu Dhabi and the gaps in the current care delivery model. And then I will give an overview about the HAD plan to improve these mental health services. And then I will talk about the ideal model, WHO Service Organization Pyramid. And then we benchmark with WHO, I'm gonna talk about the optimal mix for the Emirate of Abu Dhabi. And then last one will be the action plan. As you all know that the mental health it's not related only to treatment and rehabilitation of people affected by mental health disorder. It's mainly promoting the well-being and preventing the mental health disorders. From the literature review, most of the publications are done by the Faculty of Medicine by Professor Arifai. In Abu Dhabi, in one study, it has found that all syndromal mental disorder, it ranges from 21 to 24%. And the depression and anxiety, it ranges from 17 to 90% in Abu Dhabi population. Personality disorder among adults is 12.7, male constitute 9.8, and females 15.8. And in another study, in mental health disorder among elderly aged 65 or more is 5.1 in comparison to 3.6 for those aged 60 or more. And in the third study, somatized mental disorders among adults is 12%. From the WHO's report, which has been carried by Health Authority of Abu Dhabi in 2010, we found that in outpatient services, mood disorder comes the first, followed by schizophrenia. And in inpatient, it is the opposite. The schizophrenia is the most ranked disorders, followed by the mood disorders. Talking about the current mental health care delivery model, it's mainly hospital-based, specialized services, and centralized. It's led by psychiatrists. Mental health services in the primary health care is extremely limited. And all PHC clinics are physician-based. We don't have anything called nurse-led primary health care. Primary health care doctors are allowed to prescribe psychotropic medication with some restrictions. All mental health disorders, including the forensic cases, are seen in our specialty service. Acute and chronic cases, mild to moderate, and severe, complicated, and versus non-complicated. Specialty services get referral from all PHCs and from other hospitals in the United Arab Emirates and from other government agencies like court, police, and others for evaluation and treatment. The service specification, the service provided to all patients who are seen in the mental health entities are seen by multidisciplinary team, and they are getting evaluated by the whole team: psychiatrists, psychologists, social worker, and mental health nurses. The hours of the operation for providing mental health services is from Sunday to Thursday from 7:30 to 3:30, full team. This is in addition to the on-call services as well. Health insurance. The coverage for psychiatric illness in the Emirate of Abu Dhabi, it varies on the insurance plan. Fiqh plan, which is for national, is cover all psychiatric illness, acute and chronic, while basic plan schedule does not cover psychiatric illness except the transient cases and the acute reaction to stress. So talking about the gap analysis report, and this year, at the beginning of this year had conducted a survey of 574 health professionals in the Emirate of Abu Dhabi, which identified mental health as one of the top 5 capacity gaps affecting the Emirates. And according to the Global Burden of Disease report, WHO, for 2004, in Emirate of Abu Dhabi, 100,000 population are affected by mental health services, by mental health disorders, and only 25,000 are getting treated and they are seeking help. This could be due to the lack of the mental health services. It's only concentrated and specialized, and it could be due to the stigma as well. Demand for mental health expected to grow between 5.2 to 9.3 per annum, in line with population growth in the Emirate of Abu Dhabi. If we are talking about the health professionals, we are really have a short of staff from mental health perspective. Licensed psychiatrists only 49. If we compare this to European model, we have like 2 physicians per 100 population versus 9.8 per 100 population in Europe. Talking about the nurses with mental health qualifications, it's only 16 in the whole Emirate of Abu Dhabi. It's equal to 0.66 per 100 population. If we compare it to the European model, it's 9.6 per 100 population. To continue with the gap analysis, we have inpatient services is provided by PSP Behavior and Science Pavilion in the Sheikh Khalifa Medical City, and it has 125 beds. And we have another big institute in Al Ain Hospital, Behavior and Science Institute, which has 31 beds. And we have a third entity is the National Rehabilitation Center, which provide 18 beds for drug addict patients. Gaps in the inpatient services, it's a total of 7.4 beds per 100 population. Compared to US, it is 17 beds per 100 population. There are no specific inpatient services are available for children or adolescents or female nationals or expatriates with addiction. There is no long-term residential services for mental health disorder. Talking about the outpatient, the PSP provide outpatient services including geriatrics, child community outreach and liaison service to other non-mental health hospitals like Al Corniche, Mafraq and Al Rahba. Al Ain Hospital also provide outpatient services and a community outreach program. The National Rehabilitation Center provide outpatient service for drug and alcohol addiction to male UAE nationals only. So talking about the gaps, the outpatient level, there are no outpatient or outreach service are available in the western region of the Emirate of Abu Dhabi. So and this picture reflects the current status of the mental health services in the Emirate of Abu Dhabi. A lot of people, they don't know from where to seek help, and even they don't know that they have a psychiatric illness, they need to seek advice for it. Also, they don't know, because of the lack of the services in some of the area, they don't know from where to get this help. So to address this questions, Health Authority designed a plan for improvement for mental health service delivery model. So Health Authority adopted a new model of providing mental health services in the primary healthcare setting for management of most common mental health disorders like depression, anxiety, based on the disease burden. And this model, we called it like an integrated care delivery model. And the aim of this model is to improve the mental health services for the Emirate of Abu Dhabi through delivering integrated model of services and care benchmarked against the best evidence-based methods. The advantage of this model is it gives a lot of advantage. Easy access to mental health services in primary health care. It's more cost-effective, has less stigma, and more acceptability among population. And it helps in early detection and management of mental health disorder, and it will reduce the demand of inpatient services, and it will improve the perception of mental health and improve, at the end, quality of care. So this is the same model which was presented earlier. This is the ideal model for adopting a mental health services in any country. As we said, it starts by informal, it's kind of community care model, and then it moves up as to high specialty level. So we see that the need for these services is high at the bottom of the community care, and then it's becoming less. This is the opposite for the cost. The cost at the community level is much less than the specialty care. So benchmarking with WHO optimal mix, we proposed a mix for the services of mental health in the Emirate of Abu Dhabi based on the current availability of the human resources and facilities. We propose to get a preventive, a self-care level mental health service, primary care and hospital care, which is already existing, and inpatient, outpatient and community services. So we mainly need to work in developing the mental health services and the primary care and the preventive and self-care. So it's not a one-man show or one organization effort. It is a joint effort from the provisional body, regulatory body, all other mental health institutes in the Emirate of Abu Dhabi. So the action plan is, which was started in the Health Authority, is to establish a governance for the mental health, to establish a mental health advisory committee. We have established this committee, and we have stakeholders from all facilities, mental health facilities in the Emirate of Abu Dhabi. Then we worked with the policies and the standard. Mental health law, the first mental health law we had, it was like in 1981, and it is currently under review, and hopefully will be published next year, inshallah. Implementation of international standards and guidelines like NICE for management of mild mental health disorder. Health Authority developed the standard for diagnosis and management of mild to moderate cases of depression and anxiety at the first stage in the primary health care. And regarding the psychotropic medication, due to some restriction by family physicians, so we are currently working with our pharmaceutical pharmacy section at HAD to make some of the psychotropic medication available at the primary health care level. The other thing which really we need to work on it, the training of primary health care physician. Most of the primary health care physicians, they lack training on mental health services. So designing training program will gonna help improve their services and will give them the skills to detect and treat and diagnose mental health disorder in the primary health care. Because most of the cases, mental health disorder mainly on those people who are having the basic insurance coverage. So working with the financing department at HAD, we are reviewing the current payment mechanism and tariff that to add the mental health services for the basic plan. Also, we thought of research. We are planning to conduct a screening for anxiety and depression using a self-administrative tools and diagnostic tools in the primary health care. Regarding addressing the stigma of mental health services, it will be two-part. We will assess the perception of general public about the mental health disorders, and the other part, we will assess the need of mental health services. We will conduct a deep structure or semi-structure interview with the patients who are receiving the current mental health services and their family to know their needs and how we can improve the service. And that's all. Thank you so much.
Hello, my name is Hamid Al Hamadi. I have two questions. First question is directed to the first speaker. My question is, you've done a lot of research, and if you were to categorize which age group is the highest underserved, so is it the child kind of mental disorder, or is it the middle age, or is it the eldest people who are suffering from mental disorder? And the second question is to Miss Mariam, Amna, sorry. And the question is, the topic of mental illnesses is taboo in many cultures, and it's very particular in our culture as well. So how would you encourage kind of the local community to be engaged and to be taking the initiative to go out there and get themselves diagnosed for that? Thank you very much.
Can you hear me? Thank you very much for your question. Very important for establishing services. From the global figures available, and I would not have any country level figures for that, it seems that the group of children and adolescents is the one which is least served. In fact, there are hardly any services in a large number of low and middle income countries which are capable of handling children and adolescents with mental health problem. The other extreme of the age group, that is the old people, are also less served. So it's the extremes of the ages where the treatment gap or the service gap is actually very high. It also applies to women who get less services, although the needs are in many cases higher, and for other segments of society which are routinely ignored for many other services, including mental health, which is the group of people who are poor, the group of people who are marginalized in some way, and for example are homeless, or other groups which have less access to service, and those are all true for mental health services also. Thank you.
The second question, I don't know whether you hear me or not, is actually we're having a plan for addressing the stigma, that we will conduct a focus group discussion with the general public just to know their perception about being mentally ill. And there is a type of vignette case scenario which is invented by Professor Littlewood, which it gives the focus group a scenario of case, for example, with schizophrenia or with depression, and there are a list of 20 questions that people will be asked. Then we will gonna know their perception. We planning to conduct like 14 focus group discussion. This is one, and from there we will gonna address the stigma to design our program, promotional program.
For your time and for your presentations. My name is Isis Badawi. I'm a clinical psychologist. I am curious about your perception of prevention as the primary gap that is in mental health. I believe that issues like parenting, issues like availability of counseling in the schools would contribute a great deal to the prevention of mental illness and to the early intervention when initial problems arise. I'm curious about your impressions or your opinions about that. Any or all of you?
Well, certainly I can only completely agree with you there. And in fact, if you, it's specific, just referring back to the grand challenges, in fact, the first one, goal A, was very specifically around identifying risk factors, which of course is the idea being that if you can identify risk and protective factors, then you can modify them. And in that way, you can prevent mental disorders. And the second goal was about early interventions that could include some form of primary as well as secondary prevention intervention. So I completely agree with you on that. I suppose with the current state of knowledge, the limitation that we have is that there is a fairly small basket of evidence-based preventive interventions. Parenting is one of them, but actually there's not many more that we have. There's a very small list of evidence-based prevention interventions. So certainly I think scaling those up is an imperative, but also researching what else we could actually do to change the course of MNS disorders, I think is also extremely important.
Hi, my name is Samiha. Since Mr. Saxena mentioned that children tend to be underserved in terms of mental health treatment, I'm wondering if the HAD action plan has any plan to include counseling within schools in the Emirate?
Maybe Amna would take that. Yeah.
At this stage, actually, we are tackling this through primary health care. We didn't put a plan at this stage for school, but it will, for sure, it will be at the next stage.
Thank you. I just wanted to also mention that at the global level, we have definitely included mental disorders in children and adolescents as one of the priority conditions in MHGAP, and we certainly have a number of interventions for prevention as well as for early identification and treatment, which we are requesting member states to implement very vigorously, and I think there are some very good possibilities for cost-effective interventions on that side. Thank you.
Hi, I was just wondering in terms of countries, what are the countries that have highest mental disorder and why, if you've got like the top countries?
Shekhar, do you want to single out a country?
Difficult question, because reliable data are not available from all countries, obviously. But however, WHO has contributed to what is called the World Mental Health Survey, which uses somewhat uniform methodology across many countries, and we are also aware of many other surveys which have been done, and findings are more or less clear that all countries have mental disorders. They are present in all age groups, starting from early childhood to old age, and in both genders. However, the distribution varies a little bit. For example, the kind of conditions which are found in women are sometimes different from the conditions that are present in men, although the overall prevalence is similar. And the same is true for across countries, that in many countries the overall prevalence of what we call the severe disorders or serious disorders are about the same. The prevalence of common mental disorder varies a little more, and also the variety varies a little more. Some countries have more anxiety disorders, some countries have more depression disorders. Obviously the prevalence of alcohol disorders and drug disorders varies a lot. Some countries have hardly anything of that kind, other countries are very much higher on that. But from service organization point of view, the challenge is very similar. We have to establish services for severe disorders, and you have to establish services for common mental disorders. And the numbers might vary a little bit, but the kind of services and the amount of services which need to go into it are about the same. So from a public health viewpoint, those data really help us to the extent of going that far, that you need services, these are the kind of services that you need, and small differences don't seem to matter that much for establishing the services. For example, all countries need services at a much higher level for children and adolescents. However, the way services will be organized will vary. Some of the countries will depend much more on school system as a detection mechanism. Some other countries might have fewer children in schools, many children outside the school. So the kind of services will vary. Obviously, it will vary on what kind of professionals you have. But the need is so big, and the numbers of untreated, undetected people are so high that minor differences in epidemiology seem not to matter really. Thank you.
Any other thoughts on that?
No, I think it's an interesting question, because I think it's asked very often, and actually there are no answers to it. But I think I'm suspecting your question is really trying to ask, are there any social determinants that operate at ecological level, that is at country or even a smaller unit of population, that influences the prevalence of mental disorders? Because clearly there's no link that's obvious between the service availability and the prevalence. And that, of course, is in part speaks about the tenacity of these disorders to the treatments we have at the moment. If I can use the word resilience in that sense, these disorders seem to actually persist and run chronic relapsing courses. And the only ecological analysis that I'm aware of is one that was recently done by authors in Britain, which looked at the burden of mental illness in OECD countries and looked at socioeconomic determinants of that, and found what looked like a very interesting relationship between inequality, income inequality in countries, and the burden of mental illness. That is to say, the more unequal a country became, the greater was the prevalence of mental illness. What you make of that is not 100% clear, but nevertheless, it's an important observation, I think.
I could perhaps add one more factor which has come out to be an important factor for prevalence of mental disorders. That's the presence of conflicts and disasters, man-made conflicts as well as natural disasters, and they do seem to affect the prevalence of mental disorders in the immediate aftermath. The prevalence of common mental disorders rises about between 2 and 3 times, and even of severe mental disorders increase by about 50% more, and that seems to come down over a period of time, but maybe not reach completely the pre-conflict level always in any case. So that's one of the factors which does affect the prevalence.
Suicide in the world. I know Finland has a very hard climate and hardly no sunshine in winter. Japan, I don't know so well, but they might be very crowded over there. So could you explain to me a little bit these findings?
In my mind, I think what they point to is the fact that we still don't fully understand the socio-economic and the cultural determinants of mental illness. What seems to me obvious with these very big geographic disparities in the burden of mental illness. And suicide, I think, is not just a mental illness, it's a consequence of a number of different conditions, including mental illness, but also including a number of social factors. We simply don't understand sufficiently what determines this very vast variation in the burden of mental illness. I think Shekhar pointed to in the World Mental Health Surveys, the variation is almost tenfold in some cases. And variations are not observed only between countries, they're also very large within countries. And so I think this to me is a very interesting question. It also speaks to the earlier comment. I actually do not, the Japanese story is a peculiarly curious one, because actually Japan has one of the lowest rates of mental illness, but it has one of the highest rates of suicide. That alone is a really curious finding as well. So I don't think I have an explanation, since I also don't quite understand that story, but maybe Shekhar does.
No, I don't think we do understand a lot about the variation of suicide rate across geographical regions as well as across time actually. Suicide rate overall globally has been more or less equal, and the general impression that suicide rates are increasing to a very high level is actually not true if you count the global average. In many countries, they have increased tremendously. Take the example of Eastern European countries. The rate of suicides increased markedly starting from 1980s, early 80s actually, and they have stabilized at a very high level. Japan is a country which showed a very sudden rise in 1981 or so, and that has now stable. In Japan, 30,000 people commit suicide every year, which for the population of Japan is very high, and they have stabilized now. We don't seem to understand why some of these big changes occur. But yes, as Vikram was pointing out earlier, it has something to do with the way societies develop and function. And it is certainly true that rapid socio-economic change does give rise to a higher level of suicide, and economic inequality also does give rise to higher level of suicide, although that's not true for Japan, which has actually one of the lower rates of inequality in terms of the overall society. It has something to do, well, the prevalence of depression have something to do with the location, and those countries which are near the poles seem to have an entity called the seasonal depression, which certainly is more common there as the surveys represent. But does it have anything to do with suicide? We don't know. One factor which we really know is that those areas which have a very high rate of alcohol use have certainly a very high rate of suicide, and that's true for Eastern European countries as well as now for Latin American countries, which are very rapidly going into serious alcohol problems, and that does seem to increase the rate of suicide.
That might explain Finland.
Possibly.
I wanted to ask about the life insurance, health insurance that you talked about. I heard from some people that if you go to a cardiologist, you don't pay for the visit. But if you go to a psychiatrist, you pay a lot of money, and you also have to pay a lot of money for the medicine. So people who already feel the need to go, and they don't have the means to pay for it. I mean, what should they do then? Is that true only about Abu Dhabi, or do you see this systematic elsewhere as well? The people who already decided to go, and they have to use high resources, just won't continue.
That's true, actually. When they designed the health insurance system, they excluded the mental health services for non-nationals, but nationals, ثقة plan, they are covered for mental health disorders. For the basic plan for non-nationals, mental health services has been excluded. And that's what we are working on currently with our health financing system at Health Authority, to include the mental health disorders in the basic plan, in the basic health insurance plan. But it's true, it's excluded from the insurance plan.
And if I could jump in, that it touches on an issue that I think, Shekhar, you raised about access. As an other complicated factor in this mix that Vikram describes as a social ecology of different risks for mental disorders, and even mere access to care can itself be a driver of risk for poor outcomes in various countries. Now, either of you can jump in, but the answer to your larger question about how national systems reimburse or help marketplaces reimburse for mental health coverage as opposed to other medical coverages, there's often real disparities in terms of benefits and what individuals might be required to pay a portion of the cost of, et cetera. And there have been studies, for example, of suicide rates that individuals who are identified as at risk but have limited access to care will have poorer outcomes, both in the course of their illness and risk of suicide. So access is a huge issue, and one of these social determinants that we have great control over. We have less control over income disparity, and we have less control over urban environments, and we have less control, but we have control over access.
I can perhaps add that that's a very important issue, and the lack of parity between access to treatment and also on co-payments between psychiatric illness and physical illness is an issue that we have spoken about quite frequently from WHO, and we still find that a number of countries have a clear disparity, mostly in private insurance, but sometimes even in social insurance policies, where there is a restriction on how much psychiatric treatment can be received within the insurance coverage. And many of the insurance policies are very discriminatory towards people who have mental health needs. And that needs to be corrected, because in many countries it is actually unlawful to have that, but still nobody is paying attention. In fact, USA is one of the countries which made parity as a law. So in USA now it is much better, but not in many European countries and not in many developing countries. So that's an issue that we think is an important issue.
I was noticing about the substance abuse outpatient services in the Emirates, and that they only existed for men. And I was wondering if there are legal repercussions for men that seek substance abuse help, and if these same legal repercussions extend to women, and that perhaps that is why there's no outpatient service for substance abuse for women, or if that's just because of stigma or lack of, I guess, need.
Yeah. I think this could be due to that here culturally, the males, they can go and seek treatment and advice for drug addict, but it's kind of unlikely for females to seek advice for a drug addict. But now, before we didn't have like a number of females who have a drug addict, but I don't have exact figure, but I get to know from health professionals that this number is increasing. And I think this will be considered soon to open a place for a drug addict for females.
My question was more about how, like, if someone comes in seeking substance abuse help, say a national, are there legal repercussions for them?
There is no, if they went by themselves and they are asked for the treatment, there wouldn't be no legal consequences for this.
So I'm going to exercise one of the few responsibilities I have this evening and close our session for now. I appreciate you all being here and your interest. If you have more specific questions for the speakers, please take advantage of their presence. But thank you very much for your hospitality and your interest, and have a good evening.
Thank you.